Good morning, everyone. My name is Callie Calloway. I'm one of the residents. If everyone could take a moment and log in on WCM here, we greatly appreciate it. This morning, I have the distinct pleasure to welcome back Dr. Anli Liu, who's an associate professor of neurology at NYU. She is a clinician investigator with the NYU Langone Comprehensive Epilepsy Center and the Center for Cognitive Neurology. She's a PI of the NYU Memory and Neuromodulation Lab and an investigator at the NYU Neuroscience Institute. Her work has been supported by the NIH, the AAN, the American Epilepsy Society. I could go on with a lot of familiar names, but I'll leave it to say that clearly Dr. Liu is an established clinician investigator who has outstanding and really fascinating work that she's here to discuss with us today about the cross of neuromodulation and cognition. Dr. Liu, though, is kind of well known to our institution. She started her education at Stanford University with a BA in human biology. She went to Berkeley for a master's in cognition and a master's in cognition and education, and then UCSF, where she concentrated in medical humanities. She completed both her neurology residency and her fellowship in clinical neurophysiology here at Cornell. She then went on to Harvard Beth Israel, to complete her clinical neurophysiology and cognitive neurology fellowships. All this to say, we are very lucky to have her here today to discuss her work, and we're looking forward to your words. Thank you so much for joining us.
Okay, great. It's really nice to be back and see so many familiar faces. And I really can't believe it's been about 15 years since I've trained here. So everyone looks the same, by the way. So this is such a pleasure for me to share my clinical experience in cognitive neurology in adult epilepsy and our lab's research in memory behavior and neurophysiology with this group. And feel free to stop me with any questions, okay? All right, so I have no disclosures. So let's begin by just thinking about what do patients complain about in the clinic, okay? So both in the adult epilepsy clinic as well as the cognitive neurology clinic, here are a few of the things that I hear on a regular basis. I can't think of words, or they come to me an hour later. I lose my train of thought or forget why I walked into the room. I struggle with remembering names much more than I used to. I write down everything at work meetings now. My kids tell me I repeat myself and ask the same questions. And I need my partner to explain my medical history. So these are all examples of episodic memory impairment or personally experienced events and forgetfulness, okay? So I've sort of color-coded these kinds of complaints by the degrees of worry that I feel when I hear my patients say these things. So the occasional word-finding difficulty or losing your train of thought, that can be seen with normal cognition and certainly normal aging. I struggle with remembering names much more than I used to, and now I have to work a lot harder to write everything down at work meetings to remember what I need to. So decline from previously high-functioning baseline causes me a little bit of consternation. And then more worrisome is when I hear not only the patient, but family members saying that that the patient is constantly repeating the same questions, even when they've been told the answer just moments ago. And then finally, I need my partner to explain my medical history. I can't remember my medications, their doses, key elements of my medical history, and therefore I'm looking at my partner to fill those gaps in for me. And so one thing that I think we should keep in mind in terms of the neurobiology of memory impairment in temporal lobe epilepsy patients and amnestic MCI, which is known to be a precursor to Alzheimer's disease, is that these two clinical diagnoses share hippocampal dysfunction, okay? So, for the residents in the room, episodic memory is supported by the limbic system, but the hippocampus plays a key hub role in this system. So the hippocampus is important for binding and associating new memories, for memory consolidation and storage. And then later, when that memory may be salient or necessary, indexes the memory so that we can use it in the moment, okay? So it's really a key gateway and organizer for episodic memory impairment. So we see in this volumetric MRI study, comparing temporal lobe epilepsy patients to healthy controls on the left and amnestic MCI patients to healthy controls on the right, that there is a clear atrophy that you can see highlighted in turquoise here in the medial temporal lobe or hippocampus. So this is volumetric MRI of temporal lobe epilepsy patients minus healthy controls. You also see that same pattern of hippocampal atrophy in patients with amnestic MCI, right? So, and then cortical atrophy occurs in different patterns, including, premotor cortex and temporal lobe epilepsy patients, as well as temporal pole, whereas amnestic MCI tends to have more volumetric loss in the dorsolateral prefrontal cortex, the parietal lobe, and the lateral temporal neocortex. All right, so different patterns of cortical atrophy, shared pattern of hippocampal atrophy in these two patient groups. And so when we zoom in to the hippocampus, we can look to see how the different subfields or components of the hippocampal circuit are differentially vulnerable to pathology in Alzheimer's disease, temporal lobe epilepsy, and normal aging. So I mentioned that information is pulled in from the various sensory cortices into the hippocampus, and the gateway to the hippocampus is through the entorhinal cortex. So the entorhinal cortex kind of pulls these disparate sources of information and indexes them to delivery to the hippocampus in a topographically organized manner. And from there, the entorhinal cortex delivers information through the trisynaptic and monosynaptic circuit to have those that sort of event memory processed, where distinct features are separated, features are associated with prior experience or within this event, and then ultimately consolidated and then delivered to neocortex for long-term memory stabilization. Okay, so in Alzheimer's disease, what we see in early pathology is this dysfunction and pathology accumulating in entorhinal cortex, right, the gateway. And so patients with Alzheimer's disease have difficulty encoding new information as well as retrieving recent information. So in bedside testing, when I do list learning tasks, they have trouble registering 5 words. It takes them maybe 3 or 4 times to register all 5 words. They also have trouble retrieving that same information. So even after we've learned the 5 words, they have difficulty retrieving freely those 5 words after a delay. In temporal lobe epilepsy, we have different subfields that tend to be preferentially involved. So one key subfield is the dentate gyrus. Dentate gyrus is the kind of the inhibitory gate of the hippocampus. So not all the information that we're exposed to every day gets through and is stored for memory. So dentate gyrus is also a really important gatekeeper in terms of inhibiting abnormal hyperexcitability coming through from seizures. So we see that there is dentate gyrus dysfunction and then eventually CA3 and CA1. And so the kinds of cognitive memory impairments that epilepsy patients have tend to be with pattern separation or details, which is the function of the dentate gyrus, as well as associative recall, and then finally consolidation. So patients with temporal lobe epilepsy typically don't have problems with learning information per se, but with accelerated forgetting. So they have more difficulty in consolidating information for long-term storage and forget a lot more quickly. And then compare this to normal aging, where we see dysfunction in the tentate gyrus. So normal aging, we can see that there is more difficulty with pattern separation or difficulty with remembering details of personally experienced events. Okay. So one thing that we're beginning to be aware of in the field is that there is a bidirectional relationship between Alzheimer's pathology and epilepsy. Epidemiologically, we see in long-term studies, both retrospective, mostly retrospective and case-based, retrospective record review, that patients with Alzheimer's disease have a 2 to 3-fold risk of having later in life seizures, and vice versa. Patients with late onset unexplained epilepsy have a 2 to 3-fold risk of progressing to dementia. I'm sorry, that bullet point is, there's a typo that patients with late onset epilepsy typically progress to dementia on average about 3 to 3.7 years after epilepsy diagnosis. And so we're beginning to realize that there's in epilepsy where there's a bimodal distribution of incidence, both in the early part of life, the first kind of childhood and adolescence, and then later end of life, that there is a subset of adult patients that present with epilepsy where their epilepsy is not explained. So for the residents, we know that the 2 most common causes of acquired epilepsy late in life are stroke and cancer. And then after that, we may have patients who present with late onset epilepsy who have a fairly normal MRI, maybe some subtle white matter disease, but nothing clearly explaining why this patient would develop epilepsy so late in life. And so these patients with late onset epilepsy, unexplained epilepsy, we're beginning to study more prospectively to understand what are the risk factors that predict progression to dementia, and vice versa. In patients who are diagnosed with early amnestic MCI or early dementia, AD pathology, what are the risk factors that predict progression to seizures? So one of the things we've begun to notice, first in rodents, now 15 years ago in the Mukey lab at UCSF, and now in humans, is that if you look carefully, if you implant electrodes in the hippocampus of patients with early onset Alzheimer's disease, you see abnormal hyperexcitability, and sometimes you see seizures. So in this case report series of 2 patients with amnestic MCI, early AD, with foramen and valley electrodes, you can see that there are abnormal interictal epileptiform discharges in the left hippocampus that progress to seizures in these 2 cases. And so this makes us think, first of all, ask, what is the pathology that creates this abnormal hyperexcitability and leads to seizures? And number 2, in what proportion of Alzheimer's patients do we have to suspect epilepsy, because this is a potentially treatable and reversible cause of further cognitive decline. We know from imaging that the same pathology that contributes to Alzheimer's disease, namely tau and amyloid, in early Alzheimer's co-localized to the seizure onset zone. So in this very nice study of 8 patients with early AD that received both tau and amyloid PET, you can see that the tau is asymmetric, right? That in this particular patient, that it tends to accumulate on the left side here in these axial slices, and also amyloid PET, although less robustly. So in this series, it seems like tau is a very specific and sensitive biomarker for predicting where the seizure onset zone is going to be in patients with early AD that also have comorbid seizures. Okay, so I think I've highlighted some of the the shared kind of problems of diagnosis and pathology between Alzheimer's disease and epilepsy. Now I want to switch gears to how we might assess these things in the clinic, okay? So in epilepsy, many patients, 50% of patients report that they have a memory deficit. And this can be multifactorial, but hippocampal dysfunction is one major cause, okay? So we send them often to neuropsych testing. And of those 50% of patients that complain of memory problems, we'll capture about 50% of them on as having an objective neuropsych deficit, okay? And then the other 50% or 25% of the total, we don't see anything. They test normally in neuropsych. So the question is, are they the worried well? Are they anxious or depressed? Or are our tests actually missing something? Well, there's some clues in studies in epilepsy that our tests are limited and that they have limited ability to detect the kind of memory decline that patients with temporal lobe epilepsy have. So in this prospective study, temporal lobe epilepsy patients and healthy controls were queried about, do you think you have memory impairment? Do you have subjective memory impairment? And, not surprisingly, a greater proportion of patients on average had greater memory impairment compared to healthy controls. However, when we did the standard neuropsych testing, a list learning task in a clinical setting, so this is a one-time test where we give the patients the words and then test them 20 minutes later, they did not show any memory deficit compared to healthy controls, and with cued recall actually performed at ceiling. But when there was a surprise test given 3 weeks later, you can clearly see that temporal lobe epilepsy patients perform much worse as a group compared to healthy control. And this is the case also with free and cued recall. So this gives us a clue that one of the ways in which we miss these subjective memory complaints is that our time scale for retesting is too short. Okay, so this is another nice, very large cohort prospective study in a sample of over 1,000 healthy older women that again asked them, how would you rate your memory compared to your peers? Do you feel like you have any memory impairment? And they found that subjective memory complaint preceded clinical diagnosis. So I'm sorry, back up. So if you had subjective memory complaints, you were almost 2 times as likely to develop later clinically obvious memory impairment preceding the clinical diagnosis by about 2 decades, okay? So this is the odds ratio here, and the unadjusted odds ratio is 1.7. So women with subjective memory complaints were almost 2 times more likely to progress later to cognitive impairment compared to women who did not complain of memory. And this is true even if you adjust for comorbid depression and anxiety, okay? So it gives us a clue that we should pay attention to these subtler subjective memory decline. So in the Alzheimer's world, the name of the game is all about, can we detect these subtle deficits at their preclinical stage before it's too late, right? So this is a very famous figure published by Jack et al. Now over a decade. And this is sort of, helping us to understand how we think about the preclinical or prodromal state of Alzheimer's disease. So about 2 decades prior to clinical presentation, we can begin to see an accumulation of A-beta amyloid, right? Insoluble amyloid, followed by an accumulation of tau. So intracellular tau inclusions that together can result in abnormal hyperexcitability, cell dysfunction, and death. And then after these pathologic processes have been kind of bubbling along for years, finally we see evidence of neuronal injury that we can begin to see as atrophy in certain brain regions on the MRI, and then finally clinically apparent cognitive symptoms. So the question is, can we detect memory impairment at this earlier stage? And the reason is, now more than ever, is that now we have therapies and interventions that we can share with our patients. So there has been a whole sort of area of research on blood-based biomarkers, including p-tau217 and 181, which are, in the Alzheimer's world at least, some of the most specific blood-based biomarkers for Alzheimer's disease. Amyloid beta, 42 to 40, NFL and GFAP, which are non-specific biomarkers of neuronal injury. And then if we can determine that the cause of the memory impairment is due to Alzheimer's pathology, we have 2 new infusion therapies or anti-amyloid therapies we can offer that will probably be the most effective at this early stage. And then finally, of course, equally as important in detecting sort of earliest stages of cognitive impairment is that we have a chance to intervene in counseling patients about cardiovascular risk, exercise, sleep, and maintaining cognitive and social stimulation. Okay, so I'm going to speak for a minute on how we test for cognitive decline in the clinic. So these are the classic tests of neuropsychology. These have been used for decades. So these are 2 of the most common episodic memory tests. On the left, a test of verbal episodic memory, a list learning task, and on the right, a test of visual processing and memory, which have been around now for like 85 years, and have been minimally updated, really, since then. And, the sort of cognitive neuroscience and our ability to kind of analyze complex behavior through computational methods have really evolved. And so there are some benefits in these classic tests in that they're objective, they're normed on large cohorts, and we understand the classic phenotypes of different neurological impairments, such as idiopathic generalized epilepsy, left and right temporal lobe epilepsy, Alzheimer's disease, frontotemporal dementia, Parkinson's disease, etc. But the downsides are that these tests overlook aspects of real-world memory, the kinds of complaints that I mentioned at the very beginning of the talk, and can be very insensitive to subjective or subtle cognitive decline. So there is some work that suggests that real-world memory testing can reveal memory deficits in our patient cohorts. So this is one of my favorite experiments on the UCSD campus, where the Squire group brought a group of patients with temporal lobe epilepsy, either hippocampal disease or medial temporal lobe dysfunction, and healthy controls along a walk around the UCSD campus. And the subjects all experienced along this walk 11 staged everyday events. So, a student grabbing change from a vending machine, drinking water, picking out a book from the library, and then brought them back to the laboratory and simply asked them, what do you remember about your walk? What did you see? So not surprisingly, patients with hippocampal and mesial temporal lobe epilepsy damage remembered fewer events compared to healthy controls, right? So in fact, they remembered about half the number of events that healthy controls could immediately after the experience. And then another interesting thing is that you can see on this sort of scatter plot on the bottom right is that patients tended to remember events completely out of order, right? So This is one aspect of everyday episodic memory testing that we don't get a good sense of in our standard neuropsych. Another favorite example of a long-term retrospective sort of case records review, looking at over 80,000 Medicare recipients between the years of 1999 and 2006, and just looked at, for these patients, for these older patients, what was the rate of missed credit card payments, and found that that patients that later progressed to Alzheimer's disease had a higher rate of missed credit card payments up to 6 years prior to their clinical diagnosis. So this again suggests that if we look at more complex or instrumental activities of daily living, everyday memory functions, that we begin to capture some of the functional memory impairment that can precede clinical diagnosis. Okay, so in the second half of my talk, I want to switch gears into what our lab is doing to begin to address this question of how can we catch subtle memory decline in patient populations, and how can we track neural behavior with these naturalistic behavior tasks. So on the left, you see kind of a cartoon of how I think of the traditional ways of studying memory. So these are discrete items that are given to patients in a list, and then they're asked to freely recall. And then they're graded, do they get the answer right or wrong, right? So it's an accuracy-based metric. But these are the ways in which we're beginning to explore memory in our patients. So one of the things we do is we use short films, right, that include people, contexts, objects, narratives. Faces are a very important task stimuli. And also we ask patients to make associations. So faces to objects to contexts, right? And we capture the behavior in several ways. We ask them, instead of what are the 12 things that, 12 words that I asked you to remember earlier, we ask them just to freely recall everything that they remember about the film or the experience. And then we analyze all of the spontaneous recall. We track their eye movements as they're exploring a visual scene to understand how they're encoding visual associations and later retrieving them. We look at pupil size, right, to track for arousal. And then finally, we synchronize these behaviors to continuous neural recordings in our surgical epilepsy patients to understand what's happening in the hippocampus at the millisecond level as people are engaging in these tasks. Okay, so the two kind of arguments I want to make here, and I hope I will convince you of these things, is that number one, naturalistic memory tasks can capture complex and continuous behavior to detect subtle cognitive differences. So I'm going to sort of highlight some of the tasks that we're using. So I mentioned short films and free recall. The field of cognitive neuroscience has embraced naturalistic memory paradigms over the last few years, and we've really tried to better understand what happens in healthy human brains as we engage in films and narratives. And so we wanted to use these kind of task stimuli and insights from healthy subjects in our patients to see what we could find. And so this is a project that is led by Candace, who is a postbac in my lab and is going on to medical school. So we showed patients 5 short films and then just asked them to recall, what is everything that you remember about the films that you saw? Okay. And then we transcribed them, and we looked to see, did they remember the films? Did they remember the events within the films? And in what order did they remember them? Okay. So you see on the left side that actually patients and healthy controls were quite good, quite similar at remembering all 5 films and all films events. But when you look at the sequence recall, that patients had at least at the group level, impaired sequence recall compared to healthy controls, and there was a much higher variability. So if you zoom in on, let's say, 4 randomly selected healthy controls compared to temporal lobe epilepsy patients, you see that, so what these figures are showing you, these are 4 healthy controls, 4 temporal lobe epilepsy patients. The x-axis is recall time. The y-axis is film time. So each of these colors represents a film. So this particular subject remembered all the events within the film in the order that they happened in all 5 films. Okay, pretty good, like this, very good, right? This is also the same where they remembered most events in order as well. And this healthy subject remembered the events within the film, but the film slightly out of order, right? And when you look at the temporal lobe epilepsy patients, I think you can appreciate that some patients do really well, right? Some patients do quite well. And then other patients have very fragmented and very basically incomplete memory of the events within the films. They don't remember the films very well, or they remember them out of sequence, right? So another way in which we probe for episodic memory is we use a famous faces task. So in this task, we show healthy subjects and temporal lobe epilepsy patients 20 famous figures, and just ask them to recall, everything that they remember about this figure. Do you recognize this person? What is their name? And tell me everything. So I'm going to give you some example narrative recall, just so we can see kind of the 2 extremes.
Was the president of the state in, I think, 2004?
Okay, so maybe some of us are feeling a little nostalgic. And then compare that to
this president
patient
of the United States. He won in 2000 against Al Gore. I guess I could have said who Bill Clinton won against too, but he served 2 terms, just like Bill Clinton, and famously defeated Al Gore, despite Al Gore winning a bunch of debates because people wanted to have a beer with him.
All right. So you get a sense, right?
This is another president.
Sorry. Lost control here. All right. So when we transcribe all the speech through automated processes, we can clearly see that there is a difference in the depth of remote recall between these 2 patients, right? And then when we apply natural language processing, large language models to begin to parse out the speech transcripts, you can see that there's quite a lot of information we can get from all of the spoken recalls. So we can break down the words into nouns, proper nouns, verbs, adjectives, etc., to get a sense of what the patients are remembering, right? So in this particular task, we saw that patients with left temporal lobe epilepsy performed on average, they demonstrated poorer biographical recall. They had fewer biographical memories of these famous faces compared to healthy controls, and also compared to right temporal lobe epilepsy patients. And this is nice because this particular task has been demonstrated in the literature repeatedly in in the temporal lobe epilepsy patients to show this kind of group level difference. So we've replicated this finding, but using kind of a much richer, robust speech-based analysis. And we see that, the amount of detail that patients can remember about these famous faces tracks to existing cognitive screens. So here you can see a correlation between the percentage of biographical recall and their scores on the MoCA. So there is a good correlation, except, unlike the MoCA, the biographical refill is not limited by ceiling effect, right? So it could potentially help us to kind of distinguish between these high performers here. All right. What about word finding difficulty? This is one of the most common cognitive complaints that I hear. And this can be on so many different levels, right? So I can't think of the word. I can't think of like the rare words, or it comes to me, many minutes or hours later. And, as I'm listening to patients, I'm sort of also thinking in the back of my mind, like, how verbally fluent are they? Can I detect any word finding difficulties? Most likely I can't, right? There might be one word that the patient searches for during the clinical interview, but most often I'm not able to sort of hear it in the clinic. So this is exceptionally hard to diagnose, right? So when we take those same transcripts and we just look at the sound envelope. So this is a plot of time in the transcripts where the acoustic envelope exceeds a certain threshold. You begin to give a sense of just how continuous the speech is, right? So whereas the patient on the left uses only sparse words with lots of pauses, and the words that she uses are generally quite short, the patient on the right is very fluent, talks continuously with very few pauses, uses long words, and talks for a long time. So how can we begin to extract these metrics of verbal fluency? Well, there's a couple of things you can do with natural language processing. We can look at rate-based features. So from the total word count and content word count, we can derive features like words per second, right? So subject A and B, you can clearly see two ends of the extreme. And then we could also do something really interesting where we can calculate the word frequency. So what is the kind of the quality of the vocabulary that patients are using? So the way that we test for this in the clinic are, we might test some low frequency words or rare words, and then high frequency words, right? But most of my highly performing patients are going to get most of the high and low frequency words. So we tried to get at this feature by looking at word frequency calculation. So how we calculate this is a ratio of low frequency words over high frequency words, so rare over common words. And the way that we quantified this is that low frequency words, are defined as words that are seen fewer than 1 in 1 million words out of a corpus of 1 billion words, okay? Whereas common words are words that are seen more frequently than 1 in 10,000 words out of a corpus of 1 billion words. And so we chose this threshold. It's fairly arbitrary, but our goal was basically to get the biggest spread between patients. And so this is nice because we might begin to start to capture these elements of verbal fluency that are quite elusive to us in the clinic. And nicely, we tried to correlate this with standard screening metrics like the MoCA, or the Montreal Cognitive Assessment, which is heavily memory-based, as well as the Boston Naming Test, which is visual confrontation naming, and found that these the word frequency or word choice correlates with both MoCA and Boston naming, except without ceiling effect. Okay. All right. Switching gears to eye movements. So humans are visual creatures. We primarily learn information through vision. And, as we explore the world, we're constantly making associations of faces to objects, faces to faces, faces to contexts, right? So we were inspired by the non-human primate monkey literature to begin to sort of try to track these visual processes in real time. So I'm going to show you 2 videos, okay? So in this particular task, what we did was we asked patients to remember an association between 2 objects during the encoding part of the task. So in this case, it's the drum set and the earth, okay? And then during the retrieval, which is shown here, we just track their eye movements. How are they searching? All right, so in this particular case, before the subject actually picks the correctly associated object, we can see that their movements sort of dart from the cue to the lure to the target, back and forth like a couple times, and ultimately settles on the target. Whereas if you compare to this retrieval task, where the subject kind of goes from the cue to the and between the two objects, you get a sense that this visual retrieval search is much more chaotic, many more saccades between objects. It's takes much longer, so a very inefficient search path that gives you a clue that the patient is going to choose the wrong answer. Okay, so if we look at what happens and we try to sort of distill these eye saccade metrics over time, we can see that there are patterns. So as I showed you on the previous slide, correct trials are characterized by fewer saccades, right? Shorter trial duration and decreased entropy. In other words, it's a much more efficient search. And if we break down the eye movements in a time-resolved manner, you can see that when the patients select the correct target, their eyes go towards the target pretty quickly, so within the first second. And then the other cool thing we can do is actually get diagnostic information about this. So even during correct trials, we see a difference between healthy controls and temporal lobe epilepsy patients. So we see that even when temporal lobe epilepsy patients choose the right answer, their search path reveals a much more chaotic, prolonged search, right? It's much less efficient. And this is reminiscent of an incorrect search pattern, right? And so this kind of, you can see at the group level, and also begin to separate early on in the trial, where healthy controls during correct trials early on saccade to the target, whereas temporal lobe epilepsy patients tend to go back and forth between targets. And we can use this information to decode features like accuracy, right, with a very high outstanding performance level, as well as diagnosis. So even in correct trials, that we can predict based just on the eye tracking patterns whether or not the patient has temporal lobe epilepsy or not. Okay, so in the next remaining 5-10 minutes, I want to just sample some of the work that we're doing to pair these naturalistic continuous tasks to our intracranial recordings in epilepsy patients. So epilepsy patients in the history of medicine have been really have taught us about brain behavior relationships. So you see, of course, we know so much about our understanding of episodic memory to HM, who had a bilateral anterior temporal lobectomy due to refractory epilepsy, and thereafter developed profound anterograde amnesia, right? So he was not able to encode and retrieve anything that you taught him, right? So since then, we've tried to study brain behavior relationships relevant to episodic memory in epilepsy patients through invasive recordings. So all of us know in the room that patients with refractory epilepsy sometimes undergo surgical evaluation, invasive recording, to see where do the seizures start from in the brain and can we safely resect them. And so now the practice is stereo EEG. And in some of these patients that have non-resectable seizure foci, we can implant them with responsive neurostimulation. And so how can we leverage these tools alongside behavior? So here's an example of continuous voice recording with hippocampal local field potential recordings from the left side as the patient is trying to retrieve the correct profession associated with this face. Okay.
He was, oh goodness. Use a librarian? No.
Okay. So that was a very quiet video, but I hope you appreciate that, that basically the patient was really searching for an answer before ultimately coming up with the wrong answer. So I'm going to play it one more time. So,
Oh, goodness. Use a librarian? No.
okay. So the EEGers in the room maybe noticed that there were some important events that happened as the patient was recalling. So we see that there are two types of events that we see in the hippocampus. One is pathological, interictal epileptiform discharges, right? And one is physiological, sharp wave ripples. So interictal epileptiform discharges are biomarkers of interictal epilepsy networks, right? They're pathologic, hyperexcitable events that give us a clue as to where the seizure network is. And more recently, we've understood that these interictal discharges can disrupt memory function in real time. Sharp-wave ripples are a well-known biomarker of memory retrieval and consolidation in the rodent literature. And recently, in the last 5-6 years ago, there's been real interest in the cognitive neuroscience community to understand how sharp-wave ripples recorded from epilepsy patients can explain memory processes. And so our lab tries to look at the dynamic interaction between these pathologic and physiologic events. And so when we look at, what is the difference between successful, which is blue, and failed encoding and recall trials, we see that hippocampal ripples clearly peak during successful encoding. So if the patient sees the face and the profession and they can remember it later, there's something special that happens at about a second afterwards. We can see the kind of rippling activity. And similarly, in correct retrievals, we see that there's a clear peak in hippocampal sharp wave ripple activity prior to the correctly chosen answer. But what's interesting as well is that we can quantify when there's an interictal epileptiform discharge during encoding. This decreases the odds of encoding by 15%. Whereas if that interictal discharge happens during retrieval, it decreases the odd by 25%. And we think that's due to a directly competitive relationship between the two. Another way in which we've explored sort of real-time behavior with real-time hippocampal recordings is in our epilepsy patients that have hippocampal responsive neurostimulation. So I know the epilepsy group here is familiar with patients, with the RNS system, where we can choose to implant chronic neurodetection and stimulation devices that can detect seizures in patients and stimulate to try to abort the seizure and also neuromodulate the seizure networks. And what we've done is we sort of co-opted this system to look at the long-term recordings in these patients as they're engaging in a face profession task. And then we'll time synchronize that with the EEG. And so one of the things that we've reported is that if you look during the encoding period when the patients are trying to learn this information, that you can clearly see an increase in population level activity or gamma activity after the stimulus. Okay, another way in which we're doing this, so we are using high-resolution depth electrodes. These are Benke-Fried microwires placed in hippocampal CA1. This is a close-up of the microwire where you can see the conventional macro electrodes that we typically use for clinical purposes to assess for seizure onset zone. And here are the microwires. The microwires protrude from the tip of the hippocampal depth and enable us to see single unit or single neuron activity that's demarcated by these little tick marks, and also micro local field potential activity. So each of these micro electrodes sample from like tens to 20s of single neurons, and then whereas the macro electrodes sample from hundreds to thousands. Okay, so different spatial scales for us to understand like what is happening with these physiologic sharp wave ripples and interictal discharges. So here's just a pretty picture of sort of the kind of data that we're dealing with and kind of the scales. So on the upper raster, the white dots are the sharp wave ripples. The red and the orange are the micro local field potentials, and the other colors of the rainbow are the macro local field potentials. And we can sort of understand what's happening at different levels. So, for example, with this interictal discharge, what's happening at the macro, micro, and single unit level. Okay? And so one of the things that we're trying to do with these high resolution recordings is to pair them with visual search and retrieval. So this is the same test I showed you earlier, again, where during retrieval, the subject is asked to start with the cue and then select the target. And we see that in the hippocampus, there's clearly something different that happens during retrieval when the patient saccades to the correct target. You can see that there's a bump in hippocampal gamma activity and then in theta activity here that looks to be oscillatory and correlated with bursts of single unit activity. So we're trying to link, sort of known hippocampal oscillations and unit activity to adaptive memory function. All right, so just in summary, we've talked about how patients in epilepsy and cognitive clinic report memory dysfunction that can be missed by standard neuropsychological testing. We have evidence that naturalistic behavior and tasks that our lab has developed can capture complex behavior, such as spoken recall and eye tracking during visual search, to precisely measure episodic memory without hitting ceiling effect. And then finally, that we can pair continuous memory behavior with intracranial EEG recordings to decipher brain behavior relationships at multiple spatial scales and in real time. So with that, I want to thank the members of my lab, including those that are bolded here that did all the work, as well as my funders, and open it up for questions. Thank you very much.
I'll start. This is fascinating work. I mean, I have a list of about 20 questions that I wrote down as you were talking. But let me start with one which I'm sure everybody must have been thinking about with the epilepsy patients. What role do the medications play in evaluating these kinds of changes? I mean, I got to assume that they must have an influence on cognitive function.
They do. And, when we think of epilepsy-related memory impairment, we know that it's multifactorial, right? And there are certain medications that are infamous for causing cognitive dysfunction, like topiramate and zonisamide, the barbiturates. But we're arguing that part of this sort of dynamic memory dysfunction is related to the sort of the static hippocampal dysfunction, right, from this ongoing hyperexcitability, cell death, and dysfunction. And then there's another part of it that's dynamic that is related to hippocampal interictal epileptiform discharges. So the beauty of doing continuous recording, intracranial EEG recording with behavior is that we can begin to look at the moment by moment contributors to remembering and forgetting.
Okay.
Yeah. Yes.
So what happens if you treat the Alzheimer's patients with anti-epileptic medication to suppress the temporal lobe irritability?
Yeah, that's great. So there was a study published in JAMA Neurology by Keith Fossel that was a moderately powered study in 50 patients or so with patients with amnestic MCI due to Alzheimer's pathology, and basically treated them with low-dose Keppra, levetiracetam. and tested for memory dysfunction using standard neuropsychological tests. And they didn't meet their primary endpoint, which was improvement on memory, but they did find a statistically significant improvement in working memory, I believe. So I'll tell you that when I am in the clinic and I have patients that I suspect to, either temporal lobe epilepsy patients that I see have very active hippocampal interictal discharges, or patients with amnestic MCI, where I see that there are hippocampal discharges during sleep, or temporal lobe interictal discharges during sleep, I like to do a trial of low-dose Keppra to see if it helps. And I would say that my clinical experience has been variable. In some patients, it really does help. So Keppra 250, they clearly tell me that there's an improvement in their memory function, whereas others, it doesn't. So I think part of that is like you can try it. I think there's very low risk with this, and then just kind of understand sort of what we're treating. The other thing I like to do is to get an ambulatory EEG, a sleep EEG, because the interictal discharges will be facilitated during nighttime sleep.
So I can tell you that I've done over 100 patients for this.
Yeah.
And I've treated about 2/3 of them, and I really haven't seen much improvement.
I'm sorry?
I have not seen much improvement.
You haven't seen much improvement? Yeah, and are these patients with epilepsy or with Alzheimer's disease?
People who have cognitive impairment and have temporal lobe irritability on EEG.
Mm-hmm. Yeah, right. I mean, I think there is a dynamic component, the interictal discharges, and there's the static sort of like amyloid tau component. So yes, it's very mixed, very mixed. Yeah.
Great talk. Thank you so much. The kind of naturalistic memory paradigms that you're developing are really exciting. Do you think that they will eventually have the like sensitivity and specificity to be used as screening tools for MCI?
I do. So as I mentioned, the classic neuropsych tests are 80 years old, so we have a lot of data on large cohorts of patients, right? So, part of the, I think, resistance to like modernizing are the testing industry, right? It also takes a lot of money to do these wide population tests, but there are multiple populations for whom the standard neuropsych tests really fail, right? So children, non-English speaking, poorly educated patients, right? So what we're trying to do is bring these tools alongside the standard neuropsych tests, trying to compare them to the tests that we already use, like I showed you the MoCA and the BNT, to show that it does track with tools that we already use, but show a greater range, especially at the high end, right? So I think the first step will be to bring these digital behavioral biomarkers to the clinic, to have them kind of like what I call a cognitive snapshot at clinic visits that can be done like, with the doctor, right, in between neuropsych. And we sort of track that over time. And when we begin to see that these kind of quantitative biomarkers start kind of like gradually declining, perhaps at a faster speed that we would expect, then we begin to get more worried and refer them for further evaluation. So I do see a future in which we use these tools in the clinic, in clinical trials, in outpatient settings that have fewer resources for neuropsychologists even. Yeah.
Thank you. Excellent talk, and I'm impressed with how you're integrating existing technology now into this age-old field. In our clinics, on the memory and also on the brain fog side, we see patients where there's a huge confounder of fatigue. And it's this cognitive fatigue, some call it a cognitive intolerance, kind of an exhaustion of effort. And it's multifactorial in etiology, could be from sleep apnea, could be from long COVID and hippocampal persistent inflammation, all kinds of things. But it really affects their testing, both with the more Alzheimer's typical type of short-term registration recall, and also some of these even like temporal lobe epilepsy type factors. I could see a way maybe with the continuous recording. Could you see like more slow wave on there? Can you distinguish? Can you extract that confounder of fatigue from your testing?
Yeah, so, we've really tried to focus on episodic memory impairment, right? So we want to really understand this well. So we have not looked at this, I think, issue of processing speed and nonspecific brain fog that can be so multifactorial, such as through all the etiologies that you mentioned. But I do see that one of the applications of these continuous behavioral metrics is looking at rate-based features of behavior, right? So, for example, in the free recall, how quickly do patients speak, right? How quickly, or even like in the visual search and tracking, how quickly are they able to scan and retrieve memories, right? So these are things that we already can do with these tasks that I think will eventually be a much more quantitative, precise way to track, measures of performance like processing speed that are really elusive to us right now. So, and the other thing too is we're talking to the patients like one point in time, right? Whereas like their cognitive complaints in the real world can be occasional. They may fluctuate, right? So, the other kind of benefit of having a tool like this is we can get multiple quantitative snapshots over time. So I do think these tools will be useful for detecting processing speed related issues. Yeah.
Thank you, Anli. We're going to have to stop.
Okay, great.
We have a follow-up faculty meeting. Thank you so much.
Okay,
Really appreciate
wonderful.
you visiting with us.
Thank you. Thank you for your attention.